Before talking about mediastinal tumors, it's important to just have a good understanding of what the mediastinum is, where it's located.
The mediastinum is essentially the space in the chest between the lungs that's not the heart. So the heart sits between the lungs, but there's all this other stuff between the lungs that we call the mediastinum. And it basically consists of crossing blood vessels and nerves and just what we call in medicine soft tissue. It's sort of fatty tissue and lymph tissue, and it's all in this kind of potential space that sits in the middle of the chest. And unfortunately, when you have space, sometimes cancers develop in it.
Almost 40% of people who have mediastinal tumors experience no symptoms at all. Most are actually discovered on chest x-ray that is performed for another reason. When symptoms are present, they are often a result of the compression of surrounding structures, such as the esophagus or the heart. The symptoms may include a cough, shortness of breath, wheezing, chest pain, fever, chills, night sweats, coughing up blood, hoarseness, unexplained weight loss, or swelling of the lymph nodes. Many mediastinal tumors are benign, but left untreated, they can crowd or invade the heart, the lining around the heart, and the major blood vessels connecting to the heart. At Stanford, the treatment of mediastinal tumors really relies upon a very collaborative effort between many different specialties, many physicians, and those are going to include medical oncologists, your surgeons, your pathologists, your radiologists, all coming together to try to come up with the appropriate plan. We tend to see a lot of patients with thymic malignancies and patients with tumors within the mediastinum of all varieties, so we've already assembled a team of experts together that really can come up with the best plan for you. To do that, we need proper imaging from an X-ray, a CT scan, and an MRI of the chest.
Often patients are there's a suggestion of abnormality due to initial X-ray. It's a very quick way to get an image, but more detailed imaging we perform are the form of CT. CT is a high-resolution modality that relies on X-ray beams to create a high-resolution image of the chest. It gives us a lot of resolution in examining the tumors and see how they respond to therapy. The advantage of the PET-CT is that it can see tumor on the metabolic level, meaning we can see how much sugar the tumor is accumulating, and that is a marker of how active the tumor is. And so that gives us a nice complementary information to the CT information that we have to see how the tumor metabolically responds to treatment. So the two together basically gives a lot more information than any just one modality alone to better diagnose and also to better follow the course of treatment. We have installed a PET MR scanner here at Stanford. It's a very cutting-edge technology in which a MR scanner is built with a PET scanner. But the other advantage is that magnetic resonance imaging has better soft tissue resolution than CT does. We're able to get additional soft tissue information.
When somebody comes to a thoracic surgeon, we'll frequently get a patient referred to us who has an anterior mediastinal mass. So that is most commonly one of three things. It can be a thymoma, or a tumor of the thymus gland. It can be lymphoma. Lymphoma is a tumor of the lymph nodes, basically, but it can present as a solitary anterior mediastinal mass, or you can have an anterior mediastinal mass with other things elsewhere in the body. Or it can be a germ cell tumor, or a whole list of different types of tumors that we put under the umbrella of a germ cell tumor. We can often differentiate between those by the age of the patient, the characteristics on CT scan, sometimes some blood tests. Sometimes we don't know until we've done a biopsy of that anterior mediastinal mass.
A biopsy collects a small amount of the tumor tissue by removing it with a needle or with surgery. This sampling tells us if the tumor is cancerous, what type of cancer it is, and what stage it is. And this information helps determine what medications present our best option to conquer the cancer. The treatment of mediastinal tumors depends on the type of tumor and its location, but generally, cancers of the thymus are more likely to be treated by surgery, followed by radiation and chemotherapy. Lymphomas are usually treated with chemotherapy, followed by radiation, and germ cell tumors are usually treated with surgery, with or without chemotherapy. There are several surgical approaches to treat tumors of the thymus. The most common involves a vertical incision through the breastbone. Because no chest wall muscles are cut with this incision, pain after surgery is modest and recovery is not prolonged. Smaller thymomas may be treated with video-assisted thoracoscopic surgery and robotic thymectomy. But this is an emerging area that we are moving into cautiously, with patient safety at the forefront of our minds. For thymomas smaller than 2 centimeters, we may recommend a procedure called a transcervical thymectomy, which actually preserves the sternum and expedites healing. You have a lot of difficult decisions that you are going to have to make in a very short period of time. Here at Stanford, we see patients who have the toughest, most difficult to treat tumors. We approach these patients routinely with our multidisciplinary team that draws upon years of expertise to come up with the best treatment plan for you.